to thank Angie Stone for being here, and I'm sure she will introduce herself and tell you all about herself and her book. It's a very interesting book. We do have a copy here for checkout, but she's going to have some copies for sale. So enjoy. Oh, she's also has offered a book for giveaway. Make sure you fill out one of the evaluations in the back, and make sure you give me your name and some way to get in touch with you, an address or phone number or email or all of them, whatever you want to do. And we'll do a drawing for one of her books. Thank you, Angie.
Thank you, Maureen. Thank you so much. I'm so excited to be here this afternoon and share what my passion is and what my journey has been within the field of dentistry. My name, as Maureen said, is Angie Stone, and I am a dental hygienist by profession. And I'm also the founder and the CEO of an organization called the Hylife Oral Health Aliance, where our mission is enhancing the oral health of older adults. I never envisioned that I would be doing what I'm doing. My actual thought was when I became a dental hygienist that I would be teaching dental hygiene in a dental hygiene school. And I did that, and it wasn't a good fit. And I wondered, what is it that I'm gonna do? I thought, you know, when you're doing something and there's something in your belly that tells you that there's something more, that's the way I was feeling in the dental hygiene operatory. I loved what I was doing, and there was something more that I thought that I needed to be doing, but I didn't know what. And then lo and behold, things started happening in my life, and my path was pretty well chosen for me. On the screen, I just changed the slide here. On the screen, you'll see an older picture. This is me and my husband and our children. Our children are now 22 and 27. And the woman you see there is my mother-in-law. And I hadn't been a dental hygienist very long when my mother-in-law ended up in a nursing home. And I didn't understand what was going to happen to her dental health once she could no longer take care of her own dental health. I assumed that within the care community, there were people there who were well equipped to take care of her oral health. So I didn't worry about it. What started happening, she had COPD, and what started happening is her lungs kept being reinfected and reinfected. And nobody could figure out why this was happening other than the fact that she had COPD. As I watched this, I understood that her periodontal disease that I could no longer take care of because she couldn't get to my office was going untreated. And I also figured out that COPD and periodontal disease are very closely related. So the infection from her periodontal disease was actually causing the infections. But there were no dental people at the nursing home. And so what I watched happen became a big issue with me. You see, at that time, the laws in our state, in Wisconsin, were such that as a dental hygienist, I could not do anything in a care community without a dentist. And the dentists are not so inclined to be in care communities, like nursing homes. And I was learning all of this because this was my first exposure to all of this. And so I watched as it happened and did nothing because I was afraid. When Gladys died, I vowed that I was going to do something. At that point, I seriously had no idea what that was going to be. I made a promise that I was going to do whatever I could do to make a difference. And that was in 2003. So I started learning a whole bunch of stuff and researching and figuring out why this was happening. And along that path, my grandmother ended up in a nursing home at the end of her life. I mean, imagine, I don't know why these people think this is a great thing to do, right? Look at her teeth. She's 90 years old here. And in 2 years in the nursing home,
Oh my gosh.
that's what happened. There was a dental organization on board at this nursing home. This dental organization had seen my grandmother and made notes that there was nothing wrong. I got a call from my grandma's oldest daughter, my aunt, and she said, Angie, can you come? Grandma has a toothache. And I said, Grandma just saw the dentist. I don't understand how she could have a toothache. And so I went to the nursing home and I could see with my eyes tooth decay in every tooth, visually with my eyes. She lost 60% of her teeth in the nursing home in 2 years. And I'm her granddaughter, and I'm a dental hygienist. Do you think this puts some more fire in my belly? Absolutely. And so what I learned is that these two instances with my family are not unusual. In fact, the Surgeon General reports that elderly residents have extensive oral disease, poor oral hygiene, and suffer the worst oral health of any population. This is crazy to me. Why is this okay? I don't see the masses of people raising a stink because of this. However, if we would change out just one word, if we would change this word to what word?
Children.
Maureen, you are absolutely right. If we had this statistic about the children, everybody would be on fire. And everybody would be making a difference. I think that this whole thing is shame on dentistry, my profession. It's not the, I don't believe that it is the responsibility of the medical community to be taking care of the mouth. Because the mouth is a very specific area of the body that requires specific type of care. Would you agree? I mean, you can't go to the doctor and they can fix your teeth. So it is a dental issue, and there are issues with why we're not there. Dentistry is very comfortable in their dental offices, and I get that. I don't blame any dental professional for wanting to be in their private office. They have people that come in and pay. They have people that come in and cooperate. Who in their right mind would sign up for a program and go in and provide care for people that are difficult to work with, who have no money, and you don't have any equipment? It costs a lot of money to get the equipment in there. There are a lot of issues. But the bottom line is that this is not okay. So what are we going to do about it? I've come up with a solution, and we're going to talk about that in a little bit. But first of all, I want to go ahead and share some information about dental health that maybe isn't common knowledge to all of you who are here with me today. There's some enlightening things that people don't realize because you don't get this kind of time with your dental professional when you go. So, if you look at the screen here, oftentimes when I'm working with my dependent adult population, they will come into the dental office with situations that look like this. Let me just explain this to you so that if you see this in yourself or in any of your loved ones, no matter what their age, you kind of know and you can be alerted and you can tell someone else what you know is going on. So, in a healthy situation, the gum tissues would be on these lower teeth up to here where I'm putting my hand, okay? When we have periodontal disease, or as we age, sometimes we can get some receding gums. And so what's happened here is these gums are receded, and what you're seeing now is the root of the tooth here. This part of the tooth is covered with enamel. Enamel is the hardest substance in the body. So it takes a really strong bacteria and acid to eat away at that enamel. However, this is the root of the tooth. The root of the tooth is intended to be covered with bone and tissue. When the bone goes away, this root is extremely soft in comparison to the enamel. So the bacteria can cause what we call root decay, or cavities in the roots of the teeth. And in our elder community, what happens is we will get calls a lot saying that so-and-so just broke a tooth off. What has happened, and no one was able to realize it was happening because they can't see it and they don't know, is that tooth decay will end up going all the way through the root, and then the tooth plops off. So they think that they have lost a tooth when actually they've lost the crown of the tooth and the root is still in the mouth. Okay? So the moral of the story is be sure that you're not having, or your loved ones don't have, these receding gums. And if they do, we have to take measures to protect those roots. There are things that we can do. So that's tooth decay. There are many reasons that we get this root decay. The biggest reason is dry mouth. Okay? In the elder community, we have dry mouths that are rampant. And it basically comes because they're taking so many medications that cause the dry mouth. People that are 65 and older, I believe, are typically on 3 to 5 meds, most of which cause dry mouth. So what happens is saliva is nature's miracle and is what protects the teeth by keeping that bacteria at bay. Once we no longer have saliva, the bacteria can do its dirty work by causing rampant tooth decay. Not only do we get a lot of tooth decay with dry mouth, but people are unable to chew. If you live with someone who has a dry mouth, you will notice that it's not just, oh, they have a little dry mouth. It is life-changing. My mother is a stage 4 breast cancer survivor. She lost a breast, she lost lymph nodes, she had her breast removed, and they sent her home with me the same day. And she then went on to nearly die from double pneumonia because her immune system was so broken because of the therapy. She went through all of that. And guess what her chief complaint was? Her mouth. Her mouth was so darn sore. And then also to this day, I mean, we're 8-9 years out, she still is complaining of her mouth being so dry. She can't eat what she used to eat. She can't speak as long as she would be able to speak. She doesn't sleep as sound because of the dry mouth. So dry mouth can really cause a lot of things in our life. If you see someone who is eating and they're always needing gravy, they're always needing ketchup, they're always putting something else on their food, that's probably a sign that they're suffering from dry mouth. If there's a woman who you eat with a lot and they typically wear lipstick, if that lipstick sticks to their teeth, usually a dry mouth. So there are signs that we can help people recognize this. As humans, we adapt very well to changes in our bodies, and so we don't typically notice that we're dry until we've lost 65% of our saliva. So think of that from a dental professional standpoint. We ask someone if they have a dry mouth. They don't tell us soon enough, but we can see it. But when the patient says no, we kind of just like push it off. We have to address these things earlier. So inability to chew and a high rate of decay, also medications and radiation. If we're going through any cancer therapy, particularly head and neck, the mouth becomes a big deal. And the fancy word for dry mouth is xerostomia. Okay, that's what that means up there. The other disease of the mouth, in addition to tooth decay, are the things that we call in dentistry gingivitis and periodontal disease. So I think that we typically say, oh yeah, if someone has gum disease. Well, what does that mean? Let's talk a little bit about what the differences are. So we have this nice relationship between the teeth. Here's a tooth, this is the inside of the tooth, and this is the gum tissue, okay? When we start to get gingivitis, if we dissect that word, gingia, meaning gum, itis at the end of a word always means inflammation. So inflammation of the gums. What you'll notice with this is that the gums are maybe sore. When you brush your teeth, if they bleed, if you floss your teeth and they bleed, that is the sign of gingivitis, and that's not okay. Bleeding gums are not just normal. I have patients that sit in my clinical chair, and when I talk to them about bleeding gums, I say, Angie, my gums always bleed. It's just normal. My question to them is, okay, if your gums always bleed and that's normal, if you bumped your arm on a door and it just bled, is that normal? And if you just bumped it like every other day and it bled, are you gonna say that's normal? No, blood doesn't just happen. And so if you're seeing any of those things in your mouth, you know that you have gingivitis. The cool thing is, the good news is we can turn gingivitis around by simply strengthening the gum tissues, by getting the plaque off of the gums, because it's the plaque and the bacteria that is causing the inflammation of those gum tissues. So we can reverse that with some good home care. Let's say we don't stop that process. Then we can end up with a more serious situation, and that is periodontal disease or periodontitis. If we dissect that word, perio meaning around, don is the tooth, and itis is inflammation. Okay, so periodontitis is inflammation of the bone that the teeth actually sit in. So you'll see over here, this represents the bone, and this is the gum over the top. Good situation. When we let gingivitis progress, now what happens is we get a lot of inflammation in the gum tissues. The body tries to protect itself, so it starts breaking down the bone, and now we don't have enough bone around the teeth, and they can get wiggly. Okay? So the best case scenario is to recognize, we'll keep the gingivitis away, and if we have it, to recognize it and to get it under control before we end up with periodontal disease. Okay? So, healthy gums, you will notice that the gum tissues are pink. This is what we call stippling in the dental world. It's kind of like an orange peel. Your tissues are stippled, and there's no bleeding. I could go in and do my dental hygiene work here, and I'm not going to get any bleeding. This person, on the other hand, has gingivitis and maybe some periodontal disease going on. But you'll see the difference. You'll notice that the red around the teeth, the gum tissues get red right around the crowns of the teeth. And you'll notice that there's plaque on those teeth, and all I would need to do is literally touch that with a toothbrush bristle, and we're going to get blood. That's the telltale sign that we need to shore up that home care. Okay? I want to, maybe many of you don't understand what the dental hygienist really sees and what we love, most of us. So what you're looking at here, so if you don't get rid of the plaque, and you let the plaque sit on the teeth, it begins to harden and create what we call calculus. It's not math, right? No, dental hygienists do not typically do math. That's why we're dental hygienists. We really only can count to 32 because that's how many teeth we have. So this is the backs of the lower front teeth, and behind the lower front teeth we have two little glands that always are shooting out saliva. It's a great place to build up calculus, or tartar is the layman's term. So this is all tartar. This is after those teeth were cleaned. Is that not cool? Right? And as a hygienist, that's what we love, because you know what? We know we're making a difference there, because this is not healthy. And we know that if we remove that and we get this person on a good home care program, we are going to make a difference in their life. I will tell you though, oftentimes we get scolded at the end because they think that we took their tooth away. Because this feels very different than this. And so now they think there's holes between their teeth. It's like, no, that's what they're supposed to look like. So there's a bunch of education that goes on with dental hygiene as well. So periodontal disease, as I mentioned, will make the bone recede. So if this person were healthy, we would only see this much of their tooth. Okay? The bone has receded that far. These teeth are wiggly. And I hear people say, Angie, when we are working with our elders, they get long in the tooth. They think that the teeth grow. They don't grow. It's that we're losing the bone. Okay? So we don't get, well, the teeth appear longer, but they're not really growing. There's a different reason if they're losing the bone. So those are the dental diseases. So what is the big deal really? I mean, okay, many years ago, a lot of people would have all their teeth extracted and they'd get dentures. And people were living fairly well with dentures. However, most people at this point in time don't want to actively sign up for dentures. It's just not what we do anymore. And in the dental office, we are seeing less and less dentures and partial dentures all the time. And we're seeing many implants. It's fascinating where we've gone. What's even more fascinating to me is that this doesn't just remain in our mouths. Those diseases that we talked about give us more complications than simply in the mouth. So, if we don't have all of our teeth, it becomes more difficult to eat. And if we're talking about care communities and our older adults, it's imperative that they eat. We want them to keep their weight on. And in care communities, if residents are losing weight, that's a big deal. So one way to keep them in their weight is to make sure they have teeth that they can eat the food that they're accustomed to. How many of you have ever had a toothache? Yeah, and what'd you feel like that day? I feel like going in my bed and covering up my head and just praying to goodness that it goes away. It affects your entire body. Now, for us in this room, it likely isn't maybe that big of a deal because we can tell somebody, right? Or we can hopefully get to a dentist that can help us. But let's think about in care communities, particularly Alzheimer's and dementia, in memory care communities. Those folks don't have the ability to tell us that something is wrong. So then what the care team recognizes is that all of a sudden, those people are displaying behaviors. It's maybe not a behavior. It's maybe that their tooth is killing them and they can't tell you and they're ugly about it. Well, who could blame them, right? It's no fun to have a toothache. Weight loss, we talked about that. There is research to note that if we have fewer than 28 teeth, for every tooth we lose, our quality of life diminishes. That to me is huge. So you think about people like my grandma who lost 60% of her teeth and she's in the care community and she already is on the struggle bus, right? She's living in a nursing home, which she isn't particularly loving. And now she's lost 60% of her teeth and now she's not eating as well as she used to and now she's got pain. I mean, it's a big deal. And if we can't eat, I'm not a very happy camper if I can't eat. And not only those things, but poor oral health is associated with serious illness in all of us, but particularly in older adults because they're already dealing with a plethora of other issues. Did you know that poor oral health is associated with heart attack and stroke? Did you know that if you have untreated periodontal disease, you are 50% more likely to suffer a heart attack or stroke than someone who does not have periodontal disease? I already talked about lung disease. We know that COPD and periodontal disease are connected, okay? Diabetes. Oh my goodness, this is huge, right? If in the dental office or in the care community, I have someone who I'm working with and they have diabetes that's uncontrolled, if they have periodontal disease, I'm not going to be able to control that periodontal disease if their diabetes is not controlled. And vice versa. If someone's trying to control someone's periodontal disease or diabetes and they have uncontrolled periodontal disease, you cannot control one if the other is out of control. It's that tightly woven. Arthritis is now being linked to periodontal disease. Again, it's inflammation that's the cause. And arthritis is all about inflammation, isn't it? Periodontitis is all about inflammation. They're now also linking the bacteria in the mouth to Alzheimer's. They are noticing the bacteria from the mouth in the brains of people who have had Alzheimer's that have passed away. So in addition to the plaques and tangles that they're dealing with their Alzheimer's disease, the bacteria from the mouth appears that it can cross the blood-brain barrier, and they don't exactly know what the implications of that are, but what they know is that the bacteria from the mouth probably shouldn't be in the brain. Probably the most common sequelae, I love that word, sequelae means something that happens to you because of something else. So in this instance, aspiration pneumonia is probably the most common thing that happens to people who have poor oral hygiene. The reason for that is because the bacteria that is in the mouth, if we have swallowing issues and we aspirate those bacteria into our lungs, that gives us an infection. Aspiration pneumonia. Aspiration pneumonia is one of the biggest things that take older adults' lives. And it almost always comes from the mouth. Almost always. This is some research that I find fascinating. Research has shown that simply brushing teeth may prevent death from pneumonia, especially aspiration pneumonia, because oral hygiene, or brushing the teeth, reduces chronic inflammation that periodontal disease causes, which increases the risk of coronary heart disease and stroke, and approximately 1 in 10 cases from death from pneumonia may be prevented by improving oral hygiene. That is crazy good. I mean, especially if your loved one is that one person, right? I mean, come on, if I could have saved Gladys, I could not. I know her COPD was going to take her. I mean, I get that. You cannot stop that. My father-in-law passed away last week from COPD as well. At the end, he had 3% lung function. You cannot do anything about that. But what we can do is keep them in a quality of life where they're not also dealing with dental troubles. If we look at this diagram, the mouth is not that far from the lungs. And we have a tube that goes right from the mouth into the lungs. It's not where our bacteria and where our food is supposed to end up, but it oftentimes, when we aspirate, we all know when we do that, right? We end up coughing to get it out of there. It can cause big troubles in the lungs. And oftentimes, dentures and partials are the culprit of what is being packed and kept in the mouth. As we age, if we're not routinely having our denture fit checked, our bone recedes. The upper bone and the lower bone, it just kind of starts to go away because there's constant pressure from those appliances. So what happens, anybody know anybody that has a denture or a partial that doesn't fit so good? It's because the bone is changing and we haven't changed the appliance. So now, because it doesn't fit and they're eating, the food can get packed up underneath of there and it can sit there for a really long time. I will spare you photos of partials and dentures that I have found that nobody takes care of. It is disgusting. And so as that food breaks down and we have the bacteria and everything and we aspirate, now we're sick with aspiration pneumonia. So keeping partials and dentures clean is absolutely a must. and trying to keep them to fit with relines or using some adhesive, things like that. So what we know is that what's going on in the mouth with these diseases, it's all about infection and inflammation. And we can read all of this crazy stuff that goes in depth about infection and inflammation and T cells and white blood cells and all of that stuff. It's intricate. The only thing we need to know is that infection is infection. And when I see this tartar, again, the backs of the lower front teeth, okay, that's all tartar there, that's infection, okay? And it doesn't matter if it's in the mouth, it's operating in the body the same way as this type of an infection. These are diabetic toes, okay? Care teams are all over this because they can see it. They're all over bed sores, right, Maureen? I mean, we cannot have bed sores because we get fined if people we're taking care of have bed sores. However, what I know is that if someone has periodontal disease and I could take all of that disease out of their mouth and lay it on a surface, it would be as big as the palm of my hand. To me, if I took that infection and I put it here, that's trouble. But because nobody can see it, it goes undetected. So, the biggest thing about this whole program is we have to control the bacteria. Those of you in this room today are probably pretty darn good at controlling bacteria. And one of my mentors, Ms. Shirley Gutkowski, hygienist extraordinaire, she has this saying that could not be more true. Listen, dentistry is necessary when prevention fails. Let's listen to that again. Dentistry is necessary when prevention fails. Dental disease, tooth decay, 100% preventable. Gingivitis, 100% preventable. So it's not rocket science. It really goes back to controlling the bacteria. And if we're able to do that ourselves, we're pretty good dentally. Now, this section is for people who are taking care of others' mouths. So I'm gonna are any of you taking care of other people's mouths that are here? Okay, I'm gonna go through this a little bit more quickly because I think there's some other things that I can really make a difference with this particular audience. So care teams have troubles because people can be resistant when they're trying to take care of their mouths. So they talk to me about the resident that clinches. I'm like, it's fine, let them clinch. Because cleaning only the fronts of the teeth is better than nothing and is almost as good as cleaning the entire tooth. If you think about the surface area of the teeth, the outsides is a big surface area, and the plaque, except for the lower front teeth on the backs, typically doesn't grow on the inside because we got the tongue and everything kind of keeping it away. So it really grows on the outside. So if we can just get in and brush someone's fronts of the teeth, we're making a big difference. We're probably getting rid of 50% or more of the bacteria by simply using a toothbrush. This is a useful tool if you're brushing someone else's teeth. You'll see that these are bristles in a U shape and has a nice handle here. So you can actually, the caregivers can grab onto this handle and they can brush the upper and lower teeth at the same time. So it really reduces their time that they need to spend in the mouth getting the bacteria controlled. In care communities, they really like these things called toothettes, and they're little sponges on a stick. They're better than nothing. They're typically designed to moisten someone's mouth when they can't provide any care. But we can use them as a toothbrush. You can get them in there and move them around. Again, what we're trying to do is disrupt the growth of the plaque, and it doesn't take that much to disrupt the growth of the plaque with a toothbrush. Again, put the brush in the mouth and move it around. And this is true for yourselves, okay? Get the brush in there and move it around. You're doing good. Now, I don't know if any of you have that hygienist, and I used to be that hygienist, and I still do with my patients that can do really good self-care. We talk about 45-degree angles with toothbrush. You ever heard that from your hygienist? Yep. We're all about the 45 degrees, for goodness sake. And it makes sense because you want to get that bacteria off of the gum line, and that's where the 45-degree angle comes in, okay? When care teams are taught about the 45-degree angle, their head almost explodes because they can't even hardly get in the mouth, let alone a hygienist standing there telling them to be perfect. So what we want to do is we want to get the toothbrush in there and move it around. Oftentimes, caregivers will approach people from the front. This is not the best position. This is a really good position to get spit at. It's a really good position to get bitten. Okay, so part of what I do with care communities is I will go in and show them some modifications that they can try so they can provide better oral care with their residents. And I want to approach the patient from the side or behind. That doesn't mean that you approach them initially from the back. I always get called out, the CNAs, that are saying, you can't do that, you can't sneak up on somebody. I'm like, we're not sneaking up. We're telling them we're here, right? And that we're going to brush their teeth. And then we're getting our stuff ready. And then we're going to start our procedure from the side. Because then if someone's going to spit, you're not in the line of fire. And if they want to lash out, or if they want to punch you, I mean, this is real stuff that they deal with. And it's crazy to me to think that we are expecting those folks to be experts at oral care. There are experts at oral care, and that's called a dental hygienist. We have over 3,000 hours of education to be a dental hygienist. Why are we not the ones taking care of the mouth? Like the physical therapists are taking care of the physical therapy, and the beauticians are taking care of the hair, right? That's my soapbox, if you didn't get it. Also, we always use too much toothpaste, even with ourselves, right? So we see those commercials, and we'll see on the commercials they put all the toothpaste on the toothbrush, and they do a little swirl, right? I'm thinking, what are you doing? You don't need that much toothpaste. But the toothpaste companies, what do they want to do? Sell toothpaste. So they're going to encourage you to use that much toothpaste. You don't need that much, particularly if you're taking care of somebody else. We need this much. You can actually brush teeth without toothpaste. Do you know the only reason that we use toothpaste? What's in that toothpaste?
Fluoride.
Fluoride. Mm-hmm. Yep. It's really, I mean, they have smart toothpaste, and I mean, they're putting a bunch of stuff in toothpaste right now, and I'm thinking, oh, for goodness sake, all we have to do is disrupt the growth of bacteria, right? And we can do that with a dry brush. Actually, dry brushing removes a lot of bacteria. A lot. Okay? But we like the freshness of the toothpaste, and that's all good. But when we think of therapeutic reasons, it's the fluoride. And when you use this much, and if you have fluoride in this toothpaste, you don't want people swallowing all of that. And they don't need that much fluoride in the toothpaste, a pea-size amount. So what we encourage is a pea-size amount of toothpaste, brush the teeth, and then they don't even have to rinse. They can leave that little bit of the fluoride in the mouth, and the fluoride will help a lot if we just let it stay in the mouth instead of rinsing it out. So care teams like that. And care teams are also taught in their education. This is ridiculous, by the way. This is an excerpt from a CNA textbook. Oral hygiene is an essential part of patient care. Teeth should be brushed every morning, every evening, and after eating on every resident. They're dealing with 12 residents on a shift. There is no way the first day on the floor in their job they're feeling like a failure, because there's no way they can do this. There is no way. So what I know is that, and this pertains to all of us, right? Listen to this. The bacteria, the plaque, grows out on the teeth about once every 24 hours. You following me here? Now, it's really good to brush after each meal. I get that. Oftentimes, that's not really possible, is it? Let alone someone else brushing someone else's teeth 3 times a day and flossing all of their teeth. So, if you're doing oral care really well once a day, you are doing a good job. So now that's another thing that we can take off of the care community's head. Because they're thinking, oh my gosh, we can't do this, so we just forget it. Like, no, let's make a plan. Who's gonna care for that person's teeth once a day, once every 24 hours, we're gonna do a good job. Weekly professional mechanical cleaning of the oral cavity rather than daily chemical disinfection of the mouth can be an important strategy to prevent aspiration pneumonia. I was looking at this research and it blew my mind because what they're telling me is if a professional, i.e. a dental hygienist, can go in and mechanically clean, i.e. a toothbrush, once a week, we can reduce aspiration pneumonia. I thought, how can that even be? And then this goes on to say, results have showed that if we brush teeth once a week for 12 weeks, and then we do it once a week thereafter, we can keep that improved oral condition. That's not that hard. Putting a dental professional in a care community to brush teeth of the residents once a week can improve their oral health and keep them healthier overall. So I've implemented that into my practice, that I go in and I'm brushing teeth once a week of residents that want oral care. The other thing that I've done is I've implemented xylitol because we're talking about bacteria control. So we're controlling the bacteria once a week based in research that shows that it works. And we're also on a daily basis implementing xylitol. How many of you know the word xylitol? Just you wait. So let's talk about xylitol a little bit. And I have some xylitol samples for you all too that you get to take home. And I'm gonna run out of time. I could talk to you for like 3 hours. But I'll stay and answer any questions that you might have. So let's talk about xylitol. So your dental hygienist, in my mind, should have had this conversation with you somewhere along the way of how this bacteria is formed in the first place. So we all have bacteria in our mouths and we eat food. The bacteria in our mouths, in order to live, eat that food that we eat, okay? Things that are living have to digest the food that they eat. And after we digest things, what happens? We have excretions, right? Okay, so the bacteria in the mouth have that same process because they're alive. So we eat, the bacteria eats, they digest the food, and they poop. What's in their poop? Acid, and it is the building blocks for the plaque. Okay? So, let's all kind of do a little test here. Take your tongue, run along the outside or upper molars. Feel anything fuzzy? You might, if you brushed this morning, you might feel something fuzzy. Or any of your teeth. If you do, that's the plaque. Literally, that's the poop of the bacteria. Makes a statement, doesn't it? And when hygienists say, oh, you have a little plaque on your teeth. Okay, I have a little plaque on my teeth. What's the big deal? It's a big deal because it's really the poop of the bacteria and that's what's causing all the troubles. I can make a bigger impact with education with explaining it that way. And this goes on all day long, okay? Now, when we eat xylitol, xylitol is a natural occurring sugar substitute and it's being used with diabetics. It's awesome for diabetics. And it's being put into gum, candies, mints, toothpaste, mouthwash, nasal spray that prevents upper ear infections. We could do a whole program about upper respiratory health. But what happens is when the xylitol gets into the mouth, the bacteria eat it, they cannot digest it. Well, holy buckets. So if they can't digest it, there's no secretions. And if we ate stuff and we couldn't digest it and get rid of it, we wouldn't live very long. So the bacteria, the bad guys, kind of die off. And so we're getting a better bacterial flow, and the xylitol also helps with saliva flow. You put xylitol in your mouth and you will have more saliva. More saliva means tooth protection. So I do have some samples of some xylitol, and we can talk about that a little more. I'm gonna keep moving on. So xylitol is a miracle of nature. And again, there are companies that are doing good xylitol products. They're typically found in the health food stores. Okay, so here in the Janesville, Wisconsin area, that would be Basics, is really in this area who's carrying awesome xylitol, and the staff there is pretty well up to snuff on xylitol. There's many product lines there. I actually did research because I wanted to prove my theory that I could reduce plaque on the teeth of these elders by using xylitol. And it was actually published in a peer-reviewed medical journal called the Integrative Medicine Clinicians Journal. So let me show you. This was done here in Rock County. This is one of the residents that we saw. Now, you probably remember when you were little that they would stain, at the dentist, they would stain your teeth or your kids' teeth to show you where the plaque is. That's what we've done here.
Oh, okay.
Okay? So, but that's all plaque. Now they have what they call smart disclosing solution, and now they even have smarter than what we used here. This disclosing solution would turn red on the plaque that's been there less than 24 hours, and blue for plaque that's been there for longer than 24 hours. Okay, so we implemented a Xylitol protocol. This is 6 weeks on that protocol with no brushing, no change in the brushing. This is 12 weeks. All we're doing is providing gum or mints. That is amazing. I did not teach the care team to brush better because they don't hear that message, because they can't, because of time constraints, no interest in doing oral hygiene, and they have too many other things that they're good at, that they need to be doing for these folks. This is another one of the residents on beginning, middle, and end. Watch the staining go from a lot of blue to very little red in 12 short weeks, and we're using candy. That's good for them. So I implemented, the very first person I ever tried this weekly brushing and implementing a Xylitol protocol with was with this gentleman. He came into my dental practice. I'd been seeing him for many, many years. And the last time I saw him in my practice, his oral health was atrocious, and I'd never seen it that way before. And I asked him what had happened, and he said, Angie, I'm in a care community, and my wife can no longer help me with my oral health. Okay, so I'd had the experience of my mother-in-law and my gram, and I'm learning all this stuff, and I'd done my research, and I knew now about the brushing piece, and I thought, all right, Ed's it. This is not going to happen on my watch to Ed. I am going to help him. And so I implemented brushing and flossing weekly and Xylitol with Ed. And in 2 years, no tooth decay, no bleeding gums, and never once had to make a trip to the dentist, which was very, very difficult for him if he would have had to go. So Ed is my superstar. It's where all of this began, and I created something called the Hylife Oral Health Aliance. And again, we are committed to enhancing the oral health of older adults with our program. And what we do is we provide oral care services, the brushing, between the teeth cleaning on a weekly basis, and we supply the Xylitol. And the latest and most exciting, newest exciting thing is that the laws within the state, remember I told you in the very, very beginning that I couldn't do anything for Gladys without a dentist, and there was no dentist there? Now we do not have to rely on a dentist in the state of Wisconsin to do our work in these care communities. So we can go in and provide our scope of practice, which we've been trained to do for over 3,000 hours in our professional education, and care for these folks and provide actual dental hygiene services like you get at the dental office. So the Hylife Oral Health Aliance within the state of Wisconsin is doing that to protect the oral health of this population. Because better oral health improves quality of life. People can eat, they don't lose weight, they can smile, they smell better, and all of these things make everybody happy. They have less COPD, and they're staying more and more healthy because their mouths are healthy, and they're requiring fewer hospital stays. I think that maintaining oral health isn't about grooming. In the CNA textbooks, they brush the hair, they brush the teeth. So it's about looking good. It goes deeper than that with oral care. It is infection control, in my mind. So HOHA, or the Hylife Oral Health Aliance, we provide a lot of things to the care communities. We provide oral care training to teams and team support, resident and family camaraderie, the relationships that we've developed with the over probably 125 people that we've served at this point. The family relationships are awesome. We're there once a week, and we can take as much time as we want with these people, and we can love them, and we can care for them. And we're serving and doing something for these folks, but the people I have on my team are being filled up too, because of the service we're providing and the relationships that we create. It's just super cool. So, and we do family and group presentations, and we provide oral health advocacy as well. Our mission is enhancing the lives of these amazing people who oftentimes, when they don't fit into the usual system, are left behind. And as Maureen said, I do have a book called Dying from Dirty Teeth. It's an Amazon bestseller. It went to Amazon bestseller within 4 weeks of release in the category of dental hygiene, so it's not like Stephen King or anything. Yeah. But you can get it on Amazon as well. You can get it for your Kindle or whatever, your e-reader, or I do have some copies here today. And I guess what I'd like to finish with is, if there's anybody that you think could benefit by what we do and what our mission and our passion is, I would certainly be open to a conversation about how you think that we could help. And if we decide that we can't help through a conversation, that's okay too. And are there any questions from anybody?
How often do you use the xylitol, or how is it used, or whatever the question should be?
So the research shows that we can improve dental health by having 6 to 10 grams of xylitol a day. Okay, and so you need to kind of really look at the product and see how many grams are in each product. But in our protocol, what we hope for is that our folks will get, most of them can do mints and memory care. Oftentimes they can't do mints, so we have tooth gel that's just kind of like put into the mouth and left sit there. They'll do that 3 times a day.
Oh.
So 2 mints, best case scenario is after breakfast, after lunch, after dinner, 2 mints. And so in the general world, that's what you would do. And if you could brush your teeth in the morning and the night with xylitol, then you would get what they call 5 exposures. And so that's strive for 5. If you have 5 exposures, then you're pretty likely to get the amount of grams that you need.
So that would be after each meal, first thing in the morning, and just before you went to bed.
Yeah.
Okay.
And really, why we like to tie it to another event is so that it's easier to remember. So if you had your own schedule, that you're like, okay, I'm going to chew 2 pieces of gum at 10. I'm going to chew 2 pieces of gum at 2. I'm going to chew 2 pieces of gum, at 4. You can do your own schedule. It's more about spreading the xylitol out than front loading the 6 to 10 grams. It doesn't work that way. If you have 6 to 10 grams in one shot, it's not as effective. We want to offer that xylitol to that bacteria throughout the day. Yes, ma'am.
In an earlier slide, you showed the back teeth. Was that the same person, the before and after?
I know, right? So that all that tartar is there, right? And we call that a wall of calculus because you can't even see that there's individual teeth. And yes, so that was a before and after of that same person.
The article that talked about the brushing once a week, you've heard for years and years that not only brushing, but you gotta floss, and then you've gotta do that, and by the time they finish, you've got like 5 things during the day. I can't imagine how a caregiver could do that. But I don't have time for it all. I know that sounds, but I mean, really, my day is full.
Right.
And so, I'm not saying I only want to brush my teeth once a week, heaven's sakes, there's a whole lot more to it than that. But so what about some of these other things, like having your teeth cleaned? You did mention flossing, but isn't that still considered mega important?
You know, so there's recently was a big to-do about flossing, and it came out on all the news things and everything that, they say you don't have to floss. Okay, so here's the skinny, all right? What floss is not particularly proven to do is reduce tooth decay. Okay? So we're not flossing to stop the tooth decay. What we're flossing for is to keep the gum tissues healthy. Because what happens is that plaque, so you got the tooth and you have the gum, right? And there's a space there. And the plaque will build up in that space. And so what you are attempting with the floss is to get that bacteria out of that little space so that it's not infecting or bothering the gum tissue, okay? That can also be achieved, and dental hygienists hate to say this, right? That can be achieved where they're coming out with all kinds of interdental brushes, little picks that you can get between the teeth. So the focus of that is more interdental or cleaning between the teeth for the gum tissue health. Okay? So I don't care. I would not mind if someone used yarn. I don't care if someone uses, a brush that fits between. It's controlling that plaque so we're not getting the gums to get gingivitis. That's the importance of getting between the teeth. But using whatever it is that fits and that suits you is where the importance is.
Well, I think that's interesting because I'm not sure I've ever heard that. And so you get the feeling that if you're not flossing, that's what's going to give you a cavity. And so
there's really no research to show that.
Okay. Well,
but it is what you hear. It is what you hear.
Yeah. But it is interesting, I think, understanding that gum health is so important to your teeth in general that then you do want to continue to floss and make that
correct
definite because
it's all connected.
It's all connected.
If the gums are bleeding, then there's inflammation everywhere else too. Yes, ma'am.
I'm glad you brought up flossing because my hygienist told me I do both, the brush and the flossing. But she said if you do nothing else in the world, floss, floss, floss. More important than brushing, but it sounds like from what you're saying, that's not a true statement.
It is a true statement. The only way that I would switch that up is I would not be so adamant that it has to be floss. Okay? I would say if you only have time to clean in between your teeth to take care of the gums, or you're going to use a toothbrush, right? I would spend the time taking care of my gum tissues in between my teeth because that's where all the systemic stuff can come from. And then if you can't brush, I'm going to use xylitol to take care of that bacteria and keep those bacteria levels low if for some reason I couldn't brush. Did that answer your question? So this is a huge conundrum, as you and I talked about beforehand, for people in the general population as well as in care communities, okay? That we don't have a great way for everybody to be seen if they don't have dental care, if they don't have dental insurance is what I mean, because it can be very expensive to pay for that out of pocket. And so if that's not an option, if you can't get into the dental office, and if you're noticing that your gums are bleeding, I would absolutely start some type of an interdental cleaning program. What we know is that typically, and maybe not because you said you had the uncontrolled diabetes, I mean, we gotta get that, into play here. I don't know what your doctors are doing with that. I mean, this is a whole intricate case, right? But at minimum, at home, I would start an interdental cleaning program to try and get that bleeding under control. Typically, if there aren't other factors involved, the bleeding will stop within 7 to 10 days of cleaning interdentally every day. Okay?
Well, I mean, there's electric toothbrushes, so it actually works better. So I don't know if that's going to help.
The electric toothbrush is going to help with the teeth, and depending on what kind you have, it can help with the gum tissues as well. I still am a firm believer that we either have to get a water pick to get between the teeth, those can be a little spendy, or get some floss or some interdental brushes to get between those teeth and start working on those gums, see if we can't bring that bleeding under control. And if you can, then I think that that's a good step.
Do you know where you can look for in Wisconsin for someone who does, take people just on Medicare or maybe a sliding scale fee?
I don't know that right off the top of my head.
I believe I went to them and they said, because I have Medicare and I have insurance, but
Medicare doesn't cover anything dental.
No, exactly. So
And she doesn't have Medicaid.
Medicaid does.
Medicaid will cover
Cover some
dental
dental.
fees, and that's, I think, over there at, where you have
Health Net.
HealthNet.
Okay.
There are
All right.
very, very, very few dental offices that will take Medicaid. But in this instance, she doesn't have the Medicaid, she
Right.
has Medicare.
And I'm really
so that's the
surprised
difference.
that they don't allow you to
I
use the
know.
dental because it's not covered by insurance. And many people that don't even have insurance don't have dental. What about dental schools, dental hygienist schools? Are there any in the area? Because oftentimes
Yes.
they have open clinic time
Maureen, is
for.
a great, thank you for bringing that up to me. So there is a dental hygiene program in Madison,
Yeah, I'm sure.
at MATC, Madison Area Technical College, out by the airport. They have a beautiful clinic, and I know that it is very, very minimal amount of money to be seen by them. So I would call, and they do, thank you, Maureen, for bringing that up. That slipped my mind. But yeah, they have students that could absolutely, and then they have a dentist there too, that diagnosis and things like that. So that may be a good tip. The dental school is actually in Milwaukee at Marquette University. It's the only one in the state.
Really?
Mm-hmm.
UW doesn't have
ma'am.
one anywhere.
No, Marquette University is the only place in the state that we have dental school.
Right.
And the dental students do work as well. So, I mean, if
It might be worth looking
transportation,
into.
transportation to Milwaukee isn't an issue, that may be a good place.
Yeah, just to get, we have to go there often, just
Yeah,
to get
right.
care
Yeah.
and get this.
I would start with MATC with the dental hygiene school.
Yeah.
Yes, ma'am.
What about, I live in an apartment complex with all senior people.
Uh-huh.
Would you be able to expand something like that, senior apartments, where most people are elderly, they're one step before going to a community care center?
So what I know about the law, and just research this because I've been getting asked this question, is that if it's an ADRC, okay, then yes, we can provide dental hygiene there. But the brush and floss, we can provide that anywhere. So if it's an RCAC, then we can come in and help with oral care and things like that. We can't bring in the dental hygiene. It's not a setting because they think that those people are independent enough that they can get to the dental offices in the RCACs. In the ADRCs, they're not independent anymore. They don't make their own decisions. They don't make their own. So we can provide dental hygiene, but we can provide our brush and floss program wherever anybody lives. Thank you for being here. It comes from, again, I'm going to cry a little bit probably. I didn't pick it, right? I was presented with this, and so since 2003, this has been my mission, right? And so I have different experiences than the hygienists that are sitting in the clinical setting. I've been on the medical side. I work with medical side people, so I'm able to bring different information because I have different knowledge outside the clinic walls. And so this is, again, what's been placed in my path, and I'm trying to be a good steward. Thank you.
I agree with you. This was so informative. And I feel like I'm leaving here with a lot more knowledge up here of why I do what they tell me I'm supposed to do.
There you go.
So, thank you very much, Angie.
Thank you,
I'm so
Maureen.
glad that you joined us.